There are thousands of homeopathic remedies, each with pages of clinical experience and drug provings. Memorizing the entire Materia Medica is impossible for any practitioner. To navigate that data, we use a repertory. Think of it as a highly structured search engine, an index of symptoms rather than a diagnostic manual. This diagram outlines the process of repertorization. You drop a chaotic cloud of patient symptoms into the top, and it applies a logical process of elimination to filter out what doesn't fit, leaving you with a small, manageable cluster of similar medicines at the bottom. Notice that the funnel doesn't hand you the single perfect remedy, it gives you a short list. Isolating that final matching medicine, the Simillimum, requires extra steps. This process acts as a necessary bridge. It moves the practitioner from an overwhelming mass of data into the narrow field of possibilities required for a final prescription.
Here is the catch. That filter only works based on how you tell it to prioritize the data. You have to decide which of the patient's symptoms matter most. To do that, practitioners rely on 3 dominant frameworks for ranking symptoms: Kent, Boger, and Bonninghausen. These aren't overlapping methods you can mix and match. They arrange the hierarchy of symptoms in ways that directly conflict with each other. If you apply the wrong set of rules to your patient's specific presentation, your filter will push the correct remedy out of the funnel entirely, leaving you with a highly inaccurate shortlist. James Tyler Kent's approach evaluates the patient from the inside out, placing the heaviest weight on their inner psychology. Looking at this comparison matrix, watch the Kent column. The top slot is immediately filled by the patient's emotional expression and intellect. Only after those mental states are established do we consider general modalities, what makes the patient better or worse, followed by physical generals. This works effectively when sitting across from a highly expressive patient. If their case involves complex grief, severe anxiety, or distinct cognitive changes, Kent's framework zeroes in on those traits. But there is a clear trade-off. If a patient comes in with a strictly physical complaint, say acute joint pain, and reports no distinct emotional shifts, the top of Kent's hierarchy stays empty. Without high-quality mental inputs to act as that primary filter, the Kent method struggles to process the data effectively. When a psychological approach hits a dead end, C.M. Boger's method offers a completely different filtering mechanism. In our matrix, Boger flips the hierarchy. Pathology and causation drop into the number 1 slot. The focus is on objective disease processes, accompanying symptoms and physical generals. Mental symptoms drop to the absolute bottom, used only to break a tie. The trade-off involves cases with vague physical symptoms. If the pathology is generic, Boger's focus on physical triggers might miss a medicine that better fits the patient's underlying personality or mental state. Still, for acute cases or presentations heavily driven by physical trauma and clear triggers, Boger cuts through the noise efficiently. Sometimes patients provide physical data that is sparse, highly localized, or poorly described. This is where Clemens von Bonninghausen's method is required. In the final matrix column, Bonninghausen prioritizes locations and sensations through grand generalization. This applies a localized symptom, like burning pain, to the whole person, expanding a tiny fragment into a full profile. Like Boger, mental symptoms are pushed to the bottom, completing the matrix. The risk built into this method is scale. By elevating a local sensation to a general characteristic of the patient, you risk overgeneralizing and prescribing based on an exaggerated symptom. However, when a case severely lacks mental symptoms but presents with distinct physical sensations, Bonninghausen provides a reliable way forward. There is no single best repertory. The right choice is dictated strictly by the data you gather during case-taking. This flowchart maps the decision. For intense emotional data, follow the top path to Kent. For clear physical pathology, the middle path leads to Boger. And for fragmented local sensations, the final path directs you to Bonninghausen. Evaluating the type of information your patient provides before you ever open a reference book is the most critical skill in this process. Once you run your data through the appropriate framework, you are left with a short list of medicines. Regardless of which hierarchy you used, the repertory will never give you the final, definitive answer. You must always take that short list and cross-reference the options against the full clinical and toxicological data in the Materia Medica to validate your choice. The repertory narrows the search to a few possibilities,
but the Materia Medica remains the final authority for confirming a match.